Yeah. Tonight with us, we have Dr. Ilene Ruhoy. She's board certified neurologist. Really excited to talk about the Pentad patient and different cute questions that people have sent in. But um, as I said before I started the recording, I'm actually going to have Dr. Ruhoy sort of introduce herself and kind of explain how she got involved in this field, really, treating these patients and looking into these sorts of things. So, and you're also going to have a brief presentation just to give us some background, and then I'm going to pop back in and we're going to do some Q&A. And just so everyone knows, in the chat, you can send in your questions live and I'll read them off as we go. But first, I'll just have Dr. Ruhoy sort of introduce herself, where she's working and why she's involved in all this, and start her presentation. So go ahead.
Great, thank you, Caitlin. So I'm really happy to be here. Thanks for inviting me. Very excited to talk with everyone. My name is Ilene Ruhoy. I am a board certified neurologist. I have a PhD in environmental toxicology, and I am the medical director of the Chiari EDS Center at Mount Sinai, South Nassau. It is a new center and a new venture for the hospital. And if anyone has been, is currently, or is trying to become a patient there, I do apologize for a lot of basically the growing pains that we're experiencing and trying to find the right staff and trying to get all the scheduling correct, the EMR and all of the things, all the wonderful things that go along with healthcare and trying to help patients these days. We are learning as we go, so I appreciate your patience. But it is a very exciting center because we have 3 arms basically. So we have the clinical medical arm, which is myself and Dr. Ann Maitland. We have the surgical arm, which is led by Dr. Paolo Bolognese. And then we have the research arm, which is real exciting because we have a research team that I am also part of, and we are doing robust research into understanding more about EDS and about cranial cervical instability and Chiari malformation and all of the other connective tissue concerns that go along with EDS, as well as some other potential treatment options and other etiologies of some of the symptomology that patients often have. So it's a real comprehensive kind of center that we are trying to build, and so it is very exciting. So I'm the medical director there. It is in New York. I am currently in Seattle. I fly back and forth for now with the plan to eventually relocate there permanently. I know that's been a question that's been asked of me a couple of times when I'm coming, but I do fly back and forth, and I do a lot of remote telemedicine appointments for the center. So I'm still seeing patients actually here in Seattle, and then I'll be in New York actually in 2 weeks. So I'll be flying back and forth for a little while. And so I got into this field. I'm often told that there aren't enough neurologists in this field, and I was actually just explaining to Caitlin and Mary that in neurology training, there isn't a large focus on EDS. The focus is more on things like stroke and epilepsy and neuromuscular medicine and headache and so on. So I think a lot of neurologists sort of go down those paths in terms of subspecialty because there isn't a lot of focus on EDS, and EDS is, actually thought to be a primary connective tissue disorder and not necessarily a neurological disorder. Obviously, over the years, we've learned that there are a lot of neurological manifestations to EDS, as well as to many other diseases and disorders that we never thought were neurological in its etiology. And then when I opened up my private practice 6 years ago and just sort of had more time, I was doing a lot of autonomic neurology because I had done a neuromuscular fellowship training. And so I had noticed that a lot of these patients with dysautonomia that were meeting POTS criteria on tilt table, for example, were hypermobile. And so that became a point of interest and curiosity for me. And that was 6 years ago. And that sort of led me down the path. And so the rest is sort of history, I guess. And so here I am today, and very exciting part of the Chiari EDS Center as a medical director, and happy to lead the way, and really enjoy getting to know all of the patients and their stories. And the stories are, obviously complex and chronic, but heartbreaking, and I enjoy getting to know the patients and their families and trying my best to help them in any way that I can. So I think that's why there isn't a whole lot of neurology in this space just yet, but I really do hope that that will change over time as we do more education, which is actually one of my goals, is to sort of design more educational programs for other neurologists and as well as other physicians to join the space to really help patients, and so we can learn more and do more. So that's basically my little background of my history. Certainly happy to answer any other questions about myself at the end. I do have some slides to talk about the Pentad patient, as we refer to it, which is very prominent in the EDS population. So I am just going to share my screen. I think I can. Oh, I think I can. No, I can't. I can't share my screen. Not now. So I don't have ability to share my screen, and I don't know why. Caitlin, there you are.
Well, maybe, well, I guess I'll start then by asking, can you explain what the Pentad patient is? Where does that name come from?
Sure.
And
It's on my slides.
yeah, I'm sure.
Okay, should I send you my slides and I can just talk them through, or?
Yeah, absolutely.
Okay. I'm sorry, everyone. I thought that I was given screen sharing ability, but it doesn't seem to be coming up.
That's weird.
Okay. So, I just feel that I think the Pentad patient is a little bit complex. It'd be nice that everyone can just sort of see the list that I have instead of me just, yeah. So I need to go to, all right, this is going to be more problematic than I thought. Because I only have you under one of my 7 email addresses.
Oh, no. Here, wait. I'll just throw it in the chat. I don't care if everyone has it. They should.
I'm so sorry about this.
No, of course.
Okay. All right. So now I will send you from my personal email. You'll get it from my personal email, so you'll recognize.
Oh, good.
Okay. So.
Fast Wi-Fi at home, so I'm good.
Right, here it is. Okay. Coming your way. Okay, I just sent it.
Okay, perfect. Should come in a second.
Okay. So, should I wait for you to just pull them up, or? We can wait.
Sure. Technology, guys, you know. Oh. Got him. All right, now I'm just going to download them real quick.
Okay.
Thank you for your patience, everyone.
I could answer some of the questions in the chat.
Sure. Yeah. So one.
So Dr. Andrew Maxwell. So yes, that yes, with a couple of additions basically. So Dr. Maxwell and I are part of a large mast cell group, along with Dr. Afrin, and so yes, it is a very it is definitely very similar to Dr. Maxwell's original Pentad. In fact, that's what it was built off of. But then over the years of seeing patients, myself and I work with Dr. David Kaufman as well. We've noted some other things. And so we actually started to call them Septad and more. In fact, for the ILADS conference last year, Dr. Kaufman and I gave a talk on the Septad patient because we were adding things to it, but it became overwhelming. So we just sort of kept it with the Pentad because there truly is a lot of overlap. So yes, it is based off of the original from Dr. Andrew Maxwell. So I've already introduced myself. So I guess Caitlin, you'll have to control the slides.
I can actually give you access. Hold on, let me just.
Oh, that's great.
Oh. Oops, where are you? Maybe not. No, it doesn't want to. Never mind, I will do it.
All right, so I've already introduced myself. So yeah, I have no disclosures. And so here's sort of the Pentad. So hypermobility type EDS with mast cell activation syndrome, which is another diagnosis. So these are all actually separate diagnoses. So each bullet point of the Pentad is a separate diagnosis. So the mast cell activation is sort of the mast cells are part of the innate immune system. So our immune system is split up between the innate and the adaptive. The innate are all the first responders, all the white blood cells, including the mast cells. And then, of course, the adaptive immune system is where our T and B cells are and where the autoimmunity comes from. So one is mast cell activation. And then another is autoimmunity, which is adaptive activation. And then there's and these overlap, but they can sometimes exist in isolation to some extent. And sometimes patients are given 1, 2, or 3 of these diagnoses: small fiber neuropathy, dysautonomia, and Dismotility. And then there's also cranial cervical instability and tethered cord. And of course, in that category as well, we often see Chiari and syrinx. So again, it's becoming a lot more complex than just 5 different diagnoses, and we probably need a better phrase for it, a terminology, in order to explain the constellation of symptoms and diagnoses that we see in patients with EDS. But for now, this is sort of what works and what I think is most people understand. So hypermobility type EDS, it's a genetic connective tissue disorder. There are 13 known subtypes of EDS. Hypermobility is one that does not have the known genetic variant yet. I know that there are a couple of labs, one very prominent one who is looking very hard at genetic variants, and we're actually getting closer with regards to research on genetic contribution to the hypermobility. There is joint hypermobility, obviously. We find skin hyperextensibility with skin friability and tissue fragility. There's increased bruising often in the history. And then along with the connective tissue disorder, you have weakened vessel and visceral organ walls. And so, if you think about connective tissue, it's sort of everywhere in our body, and it's sort of what holds everything together. And when there is loss of integrity of the extracellular matrix, when there's no structural integrity of the connective tissue itself, then things just don't hold well. And so oftentimes the vessels will be weakened, and that can manifest in various ways. And often the tissue that holds the organ walls together can be weakened, and that also manifests in different ways. I think there's a lot of diagnoses of, even in pelvic organs, like interstitial cystitis, pelvic congestion syndrome, even endometriosis. Actually, there's a high incidence of endometriosis in females with hypermobility type EDS. I had, I had a patient a couple weeks ago whose basically her abdominal organs were sitting in her pelvic cavity because there wasn't enough strong connective tissue with enough tensile strength to keep things in place. Next slide. Sorry. So as I said, the gene is unknown. There is a prevalence of 1 in 5,000 people. There is a high incidence of hypermobility type EDS in women over men. We do the Beighton score to assess hypermobility, and it's basically 9 different measures that's done in 2 minutes. And that's thought to sort of not allow people time to access flexibility. Otherwise, if you were given enough time to, if I were given enough time, actually maybe not at this stage, but when I was younger, to get into a split, I probably could, even though I'm not hypermobile. So it's really, it gives a time limit for those purposes. And very often with these patients, you get this history that they were phenomenal gymnasts, or they were cheerleaders and dancers, or great athletes. And it's usually because of their joint hypermobility that they're able to move their bodies in such a fine fashion that they're very talented in that regard. So it's often part of the history that you get. Next slide. So this is the Beighton scoring, as I said, and you guys feel free to ask for these slides so you can sort of see it. I just like to give some visuals so people see it. We look for hyperextension of the elbows and the knees. We do these party tricks with, thumb flexion and little and 5th digit extension, and then of course flexing at the hips to see how far down you can touch the floor. And then there are other criteria that we look for to truly diagnose hypermobility type EDS, considering we don't know the gene to test. Next. Hello? Next slide.
Sorry.
That's okay. And so mast cell activation, it's a very chronic, very multi-system illness, and it presents in many different ways and has lots of different manifestations. And just like connective tissue, mast cells are just about everywhere in our body. They are ubiquitous. They are in high numbers in our connective tissue for sure. And so we think that there's a correlation that the connective tissue is so lax, so there's such ligamentous laxity that those mast cells, which are otherwise very well protected from things floating by in our bloodstream, are a little bit more open, a little bit more exposed. So they tend to be triggered a lot more because they're the cells that help to identify danger. And so if they sense that there is danger present, they will degranulate and release their insides. And they actually, we talk a lot about histamine, and for sure, histamine is a very prominent mediator that is released from mast cells. But there are over 200 different mediators, actually, most of which are inflammatory in some form or fashion, and most of which do some level of damage in some form or fashion. So there's a lot of mediators in the mast cells. So when there is chronic degranulation of the mast cells, you can have chronic chronic symptoms and chronic disease and chronic damage and progression as well. And these triggers with those with mast cell activation, I mean, I'm sure I don't have to tell you guys that, triggers can be anything from, someone's perfume to, obviously illness, viruses, bacterium, parasites, fungi, mold exposures, foods. A lot of people are very sensitive to certain kinds of foods. Excipients, even in the medications that we choose to treat mast cell activation, can have a particular excipient that might be that a patient might be sensitive to. Lots of patients will respond to sunlight, too much noise. There could be any triggers, but it's important to also note that there are endogenous triggers. We spend so much time trying to sort of figure out what the exogenous ones are in our environment, and that could sometimes be a futile effort, to be honest, because there's so much in our environment that we can't control. And the truth is that we just live in a dirty environment, and it gets dirtier every year. And so there are so many things that are released into our water, into our air, and we breathe it, we drink it. And so a lot of it we really can't control. I remember my PhD was in pharmaceutical residues in the waters, and I did a water sampling study across the country. And I was shocked at how many, and this is just pharmaceuticals, there's so much other stuff in our waters, but I was shocked at how many residues of pharmaceuticals were found in our water. And while they were in minute amounts, I mean, to think about sort of the chronic exposure to that, minute amounts of 50 different medications over like decades of life. We already know that in water-based species that it's actually affecting a lot of their health. That I think it plays a role in a lot of the human disease as well. So I went off on a tangent, but so we focus a lot on the exogenous kinds of triggers, but there are endogenous triggers. I mean, mast cells release, for example, mast cells, in neurology, we talk about demyelinating disease, and mast cells release proteases that destroy myelin, that break down myelin, and then myelin itself, the metabolites of myelin actually have, they have a role on inducing mast cell degranulation. So there's sometimes a vicious cycle that goes on even endogenously. Even where there are certain proteases and chimases that the mast cells release that break down, that activate glia cells that are part of our blood-brain barrier. So then it breaks down some of our blood-brain barrier, which now just sort of makes our central nervous system less protected. So there's a lot of endogenous things that go on with mast cell triggering. Next slide. And this is just, again, a visual about mast cells and basically really about histamine, which again is definitely a prominent mediator of mast cells and should at least first be addressed first and foremost, because histamine can do a lot of damage. And so this little visual just sort of shows the different organ systems involved and the different mediators involved and all the damage it can cause. Next. And then autoimmunity is the adaptive immune system. So once those mast cells, which are the innate immune system, are constantly being triggered, and there's basically a perpetual inflammatory cascade, it feels like it's not winning that war. And so we'll sometimes recruit the adaptive immune system to come and help. And so the adaptive immune system, when it's triggered so chronically, it can become very autoreactive, and that's what results in autoimmunity. So it can create autoantibodies to pieces of our cells, which is what an autoimmune disorder is. And because there's been so much inflammation and degradation of cellular parts, sometimes those little parts that sort of float by our organs that make these immunoglobulins will recognize that little piece of something and think that's foreign, it must not be there, but it's actually part of our cells. So it'll create an antibody against that it becomes the antigen. So it creates an antibody against that particular antigen, which then creates autoimmunity. And it doesn't necessarily mean that you have the autoimmune disease that's associated with a particular autoantibody. It does show that there is autoreactivity, but certainly for some, they ultimately evolve into developing an autoimmune disorder as well. And those exposures are basically the same as mast cell activation. Next slide. Next slide, please. So dysautonomia. So lots of patients are diagnosed with POTS, postural orthostatic tachycardia syndrome, and then some have orthostatic hypotension. The difference, of course, is there's blood pressure involvement with orthostatic hypotension. It seems like the baroreflex sensitivity is higher in hypermobile patients, so those baroreceptors sense any change in blood pressure, and they either unload or overload the receptors, basically, and so it can create different in the vasoconstrictor properties of the vessels, and so have effects on how our blood pressure and even how our heart rate will respond to changes in position. And so I like best to confirm by autonomic testing, which is not only the tilt table. There are specific criteria on the tilt table to meet a POTS diagnosis, but also heart rate, deep breathing, Valsalva, and then the QSART, which is a sweat test. You know, I think that POTS is often sort of the surface of dysautonomia in patients. I think it's very easy to meet the criteria of POTS. So many patients, you know, you can give a clinical history that screams POTS, and you can be diagnosed with POTS without any true objective testing. I think often, like I said, POTS is just sort of overlying more dysautonomia or more autonomic dysfunction underneath. It doesn't necessarily change management, certainly not initially for sure, but sometimes it's important to know if there's something that lies within, but certainly everyone, many patients with hEDS have POTS. Next slide, please. And so orthostatic hypotension, as I said, it involves the blood pressure, so there's a sustained reduction of blood pressure, usually of the systolic. Next slide. And it's within 3 minutes of standing or head up tilt on the tilt table. It can also sometimes have a reduction in the diastolic blood pressure, though I regularly see it in the systolic pressure. And this could be related to either volume depletion or impaired peripheral vasoconstriction, or both. So when we stand, our legs and their vessels are supposed to pump the blood back up, so the vessels get more constricted, and oftentimes the leg muscles will be involved with active standing, which is why actually some take issue with the tilt table, because it's passive head up. So we're not engaging the lower limb muscles, which do play a role in sort of pumping the blood back up, but it does impair return of blood to the heart, and so it can impair perfusion to organs, and which is very much involved in what we think with regard to some of the neurological manifestations of the brain fog, of the headaches, of the dizziness, and so on. And it could really be due to a variety of medical conditions. Dysautonomia is not hard to come by, especially with any kind of neurodegenerative disease. Next slide. And so POTS is much more prevalent than orthostatic hypotension, as I mentioned. Many patients with EDS are diagnosed with POTS, and that's diagnosed by an increment of 30 beats per minute of an increase of heart rate within 10 minutes of standing. And what's important is that it has to be sympathetic. Symptomatic. It is a sympathetic response, and so you have symptoms. And so when we do tilt table and autonomic testing in the clinic, we are asking the patient, even though we might see objectively that their heart rate is increasing, we ask what their symptoms are. We actually do an exam. We look for pallor. Some patients have had syncope, have fainted during head up tilt. So it has to be symptomatic to really sort of have an objective diagnosis. Next slide. So I listed the symptoms, and again, most of them are orthostatic in nature, but there are patients that don't have orthostatic symptoms, but still even meet the criteria of the diagnosis of POTS as well as dysautonomia. And this, I think, goes along with the underlying reason for the autonomic dysfunction, which sometimes is related to sleep-wake cycles, sometimes related to poor gut function, which can be also related to small fiber neuropathy, since the small fibers control our autonomic nervous system as well as control motility. It could be related to the functions of other organ systems as well. So as I said earlier, it's what makes describing the pentad so complex sometimes is that there's a lot of overlay. And so it's really hard at least at this stage of our research, to dissect, what comes from what. But we do know that they very often present together. Next slide. So these symptoms can be exacerbated by medications that we use for EDS and its symptoms, which, sometimes the joint pain or the muscle pain that comes along with EDS, some of the treatments that we use for that can exacerbate the autonomic symptoms, but even the medications that we use to treat the dysautonomia alone can exacerbate the symptoms. And that we think is sometimes related to the mast cell, because of even not only the medications, a lot of patients with mast cell are hypersensitive to medications in general, but as I said earlier, the excipients can be a problem. They can also be exacerbated by prolonged recumbency. So patients with EDS are often have a difficult time being mobile. They often have excessive fatigue. So they are not as active as they would like to be, or maybe as they even once were. So to not have prolonged recumbencies can be a challenge for them. Heavy meals, heavy heat exposure, intense physical activity, illness certainly. Illness is known to flare most, if not all, neurological disease. So there's a lot of things that can exacerbate it. So even when we get patients, well managed, and we have a good regimen where at least their symptoms are tolerable and they have a little bit more function to their life and a little bit more quality of life, the smallest thing can send them into a flare. So we really, we have to we work together to try to nurture these patients so they're not as vulnerable to flares is really our goal. Next slide. And this is just a visual to sort of show that when we stand, we have a pooling of the blood when there is dysautonomia. So again, there isn't enough vasostrictive response in the lower limbs to sort of push the blood back up. The venous valves sometimes need more support and don't have a lot of support either from the peripheral muscles or from the autonomic nervous system. And so the blood tends to pool in the splanchnic mesenteric beds. And so that's why it's a positional kind of change of heart rate and when patients become symptomatic. Next slide. So small fiber neuropathy, another one of the diagnoses. So again, as I've already said, related to POTS, because it does play a role in our autonomic nervous system function. It also plays a role in the motility of our gastrointestinal tract. And if things aren't moving all that well, then obviously waste byproducts become stagnant. And so then you have altered microbiome, and that's where diagnoses of SIBO come in. Sometimes, people refer to leaky guts, but regardless, we do know that when there's gut inflammation, then there's inflammation elsewhere. In fact, the gut-brain axis has been, well documented at this point. And so there definitely is an interplay between the enteric nervous system, the central nervous system, and the peripheral nervous system, of which the autonomic system is a part of. And so there's a lot of intercalation here. Autonomic symptoms, as I've already mentioned, temperature dysregulation, which technically is an autonomic symptom, but sometimes presents as itself. In fact, a flare can be, for a lot of patients, they get into a hot shower or they go out in the sun. And then small fiber neuropathy has been increasingly identified in hypermobile type EDS, and we think it's related to the neuropathic POTS that we see. And what's interesting, and the reason why I sort of pointed out separately, is that I've been also adding so the way to diagnose small fiber neuropathy is through a skin biopsy, which they measure the density of the fibers, but I've also been adding a synuclein staining to it. So the lab that I use does not only small fiber neuropathy, but also tests for the presence of synuclein protein. And synuclein, we've known about synuclein for a long time, and synucleinopathies are one of the well-characterized neurodegenerative disorders in neurology. In fact, the most common one is Parkinson's. But synuclein, it's not related to what we think of as Parkinson's disease, and certainly there's no evidence to even think that hEDS is related to Parkinson's. But what we do think, and there have been small studies that show that synuclein seems to be an indicator of a more severe kind of POTS-like presentation or a more severe dysautonomia, which is interesting because the synucleinopathies, as we know of in neurology, which is Parkinson's and MSA and Lewy body dementia and so on, have an autonomic component. So we think the synuclein is more about the dysautonomia than it is about anything else regarding those neurodegenerative diseases. But That's sort of a new research focus that we've had for the EDS population and their small fiber neuropathy. Next slide, please. And so, as I mentioned, with small fiber neuropathy, you do get dysmotility, and very often it's where it slows it down. There is occasion where it speeds it up, and so patients will have loose stools, if not outright diarrhea. But the majority of patients will have slowed motility, and often gastroparesis. And so, not only is there SIBO and leaky gut, and as I've already mentioned, there's a lot of interplay between gut inflammation and other things, especially it could change our mental clarity, it can change our cognition, it can change our mood, it can change our energy state, it certainly affects our skin. And it definitely creates more joint pain and joint inflammation. Next slide. And so then the final part of the Pentad, of course, is what affects from the connective tissue, things like cranial cervical instability, Chiari malformation, syrinx, and tethered cord. And while I don't list them all here, cranial cervical instability is something that we're commonly finding now with patients who have severe EDS, or at least, and it doesn't necessarily have to be, clear EDS. It seems that there's a small segment of patients that, while they don't have EDS, have had injury to have it like concussions or whiplash, and even infectious illnesses that are systemic and chronic that create lots of inflammation for a very long period of time that result in ligamentous laxity of many different joints, but importantly, the cranial cervical junction joint is a very critical one, and despite the fact that it's small, it's actually held together by many different ligaments, and it houses the lower end of the brainstem. It houses vasculature that feeds the brain and drains the brain. It houses CSF compartments. So it's a very critical one to our overall physiology. And so when there's an unstable joint there, and when there's cranial cervical instability, it becomes problematic and is often responsible for a lot of the symptoms that we see, certainly when there's progression, certainly when there's poor response to a lot of the commonly used medications. And the definitive solution for true cranial cervical instability is actually cervical fusion, is a surgical intervention. But that C0 to C2 complex is the most mobile portion of our cervical spine. So if it's not functioning properly, then more distal down the cervical spine, you can have other kinds of pathology that are obviously much more conventional, much more easily found on imaging of an MRI of the cervical spine. Radiologists will often report C4, C5, C6 stuff in EDS patients, but we often overlook looking more proximal on that cervical spine to look at the C0, C1 joint and then the C1, C2. Because sometimes that's where the problem starts. And the spine is interesting because, it's meant to sort of, to distribute the burden of the spine, of moving our entire skeleton across all the vertebral bodies. But when, one or two or three are offline, it can sort of create all problems downstream. And so it's important to sort of address CCI when it does exist. And it can, because of what it houses in that joint, it can cause what we refer to as the cervical medullary syndrome, which is compression of those pieces of anatomy that I had mentioned that are within that joint. And so when you have compression, when you have brainstem compression, which has certain nuclei, which speaks to the hypothalamus and sometimes speaks to parts of the cortex, then you can have a lot of different neurological manifestations. And then if you compress any of the vasculature, then you can have impaired blood delivery or blood drainage, which is just as important as blood delivery. You can obviously compress flow of CSF, which is, what we think causes a syrinx when there's a Chiari, is that there's a disruption of flow of CSF. So the syrinx then develops, which then becomes another place for pressure changes, which can create its own set of problems. So it's really important to address the cranial cervical junction for all EDS patients. And I try to regularly do that, especially when the history really indicates it. I think that, Dr. Bolognesi and I talk a lot about the components of CCI, because obviously the answer is surgery, and no one's thrilled about getting surgery on their cervical spine. But the components are clinical history, the morphometrics on MRI cervical spine, and then response to traction, because the fusion itself can somewhat can simulate the traction. So it's important to sort of assess how the patient feels if they're under even minimal traction. Next slide, please. And this is just a picture of the pretty cranial cervical junction. I don't know, I like anatomy pictures, but we'll pass that one for now. And I talked so along with, again, this is thought to be related to the connective tissue not holding things in place well enough. And so I listed obviously lots of other things that can be seen of the same anatomy structure because of connective tissue disorders, including sinus stenoses. We're finding more and more, we do more vessel imaging now than we ever did, because we're finding that, the vessels actually they have connective tissues within their walls as well. And so sometimes they're actually either too dilated, but oftentimes they sort of collapse easily if they don't have enough pressure within their lumen. And so we see stenosis from that, which also creates its own set of symptoms. So it's important to recognize all of these things. Next slide. And so I just point out that a lot of my colleagues and as well as myself, we're finding more and more that, to think that if we're born hypermobile as a pathologic state really doesn't sit well with me. It doesn't really make a whole lot of sense. So it's almost like this two-hit kind of hypothesis that we've had in medicine about several different things, that you're born with one hit, which is usually a genetic predisposition. And then there's a second hit that sort of sets the trigger off. And so, so we think that infection is a second hit. I think I do believe it's infection, but I think it's other exposures as well. As I've already mentioned, I think our environment is out to kill us all, but there's a lot of things that we can control, but a lot of things that we can. So I think that there's some exposure or physical trauma or it could be, it could be true physical trauma, or it could be trauma from like a life event. I've heard some stories that certainly would send a body into a state of shock and a traumatic state that could also be that second hit. So there's a catalyst that sort of sends a hypermobile patient into these different diagnoses. And it's important to sort of recognize what they could be, because if you can stop the process, then everyone's got a better chance. Next slide. And so, so as I've already mentioned, is that we're starting to call it the Septad now, but the truth is I think we're up to like number 10. So I think I'm going to just stop counting. But we're recognizing that this is a multi-organ, multi-systemic, multi-exposure. I don't think it's just a pathogen, as I said, a multi-exposure kind of syndrome, where there's this constellation of things, and there's got to be some common denominator in all of it. I think that all these diagnoses are often given in isolation. A lot of patients come and they've seen 50 different doctors, and they've gotten different diagnoses from them. But to put it all together as a puzzle is important, because I think that it'll help us in learning about more treatment options. I mean, the number of medications that patients are on. I mean, polypharmacy in and of itself can be an inflammatory challenge to the body. So, I think that there's a lot of research and a lot more information that we need to learn, and that's what I'm excited for the center to do. Sorry about that. Okay, that next slide, I think that was it. Oh, that's just a nice a nice diagram. I didn't make that, actually. One of my friends did for me. I don't know PowerPoint all that well, but that's sort of just what I described. So that's my slideshow. So I'll take any questions.
Awesome. Thank you. Thank you, Dr. Ruhoy.
You're welcome.
Okay. So there are a couple of questions that came in the chat. And again, if you have questions, please feel free to use that. I'm going to ask them as we go. There was one that came up very that I think is relevant to kind of what you were talking about. So what are some of the neurological symptoms of CCI to watch for in an EDS patient?
So it really, it can depend upon what you label as a neurological symptom. I mean, so, obviously pain is considered a neurological symptom, and, but I will, obviously specialists other than neurologists will work with pain, but so neck pain and headache, of course. So neck pain and headache, very common. There's often a positional component to it. So you might always have a chronic baseline level of headache or neck pain, but you turn your head, you flex your neck, you extend your neck, it could increase or it could get better even. So there's a positional component to it. There's also often positional vertigo, positional dizziness. Again, you could have a baseline level of dizziness or lightheadedness even, but I have lots of patients who extend their neck and they pass out. So so there's a lot of positional components in that regard. But also, just because of the compression that can take place, there's often cognitive dysfunction, there can be swallowing problems, there can be visual problems. Certainly, it can affect the posterior circulation. So sometimes there's things like, spots in your vision, or what we refer to as visual snow syndrome, those kinds of things. There sometimes can be radiating symptoms. The C2 nerve root is sensory, and so sometimes you can have some radiating kind of sensory disturbances. And so I think that it really depends upon how severe the CCI is, and also what position you maintain. Also, because of the compression of the brainstem, there's very often circadian rhythm kinds of dysfunction, because there is communication with the hypothalamus, and it can change the neuroendocrine axis function. And so sometimes that in and of itself changes energy states. And so, I often hear about insomnia and difficulty sleeping, but there should also be a focus on the wake cycle, right? So we get this history of, fatigue during the day, but insomnia. And so, there's often a very, I think, flippant way of thinking, well, you're not sleeping well, so of course you're tired during the day. But the truth is that our 24-hour circadian rhythm is sleep and wake. And so there's dysfunctions in both. And that's something that we're not regularly, talking about, I think. And so I think that, and for sure, we focus in on the sleep because we need sleep. I mean, sleep is critical to human physiology. It's also when the glymphatic system of the brain is most active, right? The glymphatic system is the system of the brain that helps to rid the brain of the cellular debris and the metabolic waste byproducts that build up from all of the many metabolic processes that go on in our brain every day. So it has to work, and it's most optimal when we're in certain stages of sleep, and so we have to sleep. So I totally get the prominence of focusing on the sleep, but there's also dysfunction in the wake state, which is why we think about the fatigue. I even think that some of the PEM, even some of the cognitive dysfunction, I think is related to this wake cycle dysfunction as well. And perhaps if we focus on the wake cycle, we would better fix the sleep cycle. Although, I mean, that's just my thought. We haven't, the research isn't there just yet. But so I think a lot of this comes from CCI, from, again, the compression of the medulla oblongata, the compression of the CSF compartments, the compression of the vasculature. But sometimes CCI can be, the symptoms can be either incredibly severe or incredibly mild, and it still exists. So there's so many other things that play a role that I think are important. So you just basically need to see someone who's familiar with CCI and to really to address for it. So we recommend patients do traction trials to sort of see if traction. So the question is, if we lift the skull up off the cervical spine, is there any improvement in symptoms? And that's something a patient can do at home, certainly. I know lots of patients are afraid of doing it because they're afraid of the rebound or afraid of flaring their symptoms, which I completely understand. Some physical therapists are familiar with CCI, or at least familiar with EDS, can help do manual tractions, and I definitely support that. Sometimes in the clinic, I will press down on someone's head and then lift up on their head, and they could certainly do that on their own if they have someone with them, of course. But again, because we're trying to sort of answer the question, if we create some space in that little junction in that C0, C1 joint, does anything improve? And it doesn't have to be a magical improvement, but even a subtle improvement is important to know. So I think that's it. So yeah, I guess I'm rambling about your question because it's not an easy question.
None of these are going to be easy. I have news. They keep coming in. But you kind of touched on this. So one question that came up was, is PT a valid intervention for mild CCI?
I think it is for a period of time. I mean, we have to recognize that at its core, CCI is an anatomical issue, right? So, and so there's nothing that's going to correct anatomy permanently other than surgery. And so while I think PT, certainly for mild CCI, I fully support trying PT for a period of time and seeing if you can get a sustained response. Most of my patients and the patients of some of my colleagues who work with CCI patients, their patients have to go every week. And I will say that most of them don't mind that. So I'm not even saying that that's a problem. Most of my patients say, I'd rather go to PT once a week. I get some exercise in, I learn some safe exercises for my other joints, and I get some relief from my CCI. And I'm good with that, certainly. But we do have to recognize that it's an anatomical issue, and all the exercise and adjustments won't necessarily correct it for the long term. Obviously, we can never say anything is permanent, because I think that we haven't been doing this long enough to say that anything we do is lifelong. But certainly we know that fusion has at least a more sustained response than physical therapy does. But again, I have a really dear friend who's a PMR who runs a practice basically for EDS, but does a lot of CCI. And my patients that I send to her and her practice get phenomenal responses from her rehab program. So I'm a believer for sure. I think the jury is still out whether it's a sustained response where we're completely obviating the need for surgery. So that's my thoughts on that.
So can you just go over what the symptoms of a quote pressure headache might be?
Pressure, obviously. So a pressure headache is feeling like your head is going to burst, like feeling like there's too much fluid, or as one patient said, too much brain in my head. So obviously a very common diagnosis of elevated intracranial pressure can feel like a pressure headache. Those kinds of headaches are usually worse when you lie down. So if it's truly because there's increased pressure, so a pressure headache can be without elevated pressure, but if it's truly due to elevated pressure, it'll worsen when you lie down. It'll improve slightly when you stand up, though not greatly. But it feels like your head is going to explode. It feels like you have too much pressure. Often there's pain behind the eyes. Sometimes there's pulsatile tinnitus. That pressure can come from any of the fluid compartments of the brain. So again, there's the arterial side, there's the venous side, there's the CSF compartments. So any of that can feel like there's just too much fluid, and so it feels like there's just pressure. And very commonly, again, it's like you even feel pressure in the sinuses of the cheek, so the maxillary sinuses, the frontal sinuses. You can feel pressure in the sinuses, in the ears, as I've said. So that's what it feels like. And I'm sorry to keep using the word pressure, because I know you're not supposed to define something using the same word in the definition. I remember all those grammar rules from elementary school, but it really does feel that way, and it's pressure from different components and from different pieces of anatomy.
And then just before we move on from the PT thing, a couple of people have asked for the name of the PT that you mentioned. I don't know.
I know, I'm happy to give her name. Dr. Alyssa Zingman, who runs PRISM in Silver Springs, Maryland. And she has a phenomenal rehab program specifically for EDS patients and addresses the CCI.
Yeah, and I'll grab her stuff and send it to, I'll have Mary send it.
I would bet that most people on this call know her already.
You know her. Perfect. So just talking a little bit more about symptoms, one of the questions that came in before, actually this was also asked, so can mast cell, like chronic mast cell activation, can that cause tissue breakdown? Can that do some permanent irreversible damage, or do we think that it can be reversed?
I think so. I don't think mast cell can be cured. I think, I guess to answer the first part of your question, yes, it absolutely can do tissue damage. Mast cells within their guts, they not only release histamine, as I mentioned, there's a lot of mediators. One of the mediators, for just one example, is MMP9, which breaks down collagen type 4, 5, 9, and 10. I could be wrong on 1 or 2 of those, but my point is certain collagen types, it breaks those down. I've already mentioned the example with regards to the protease that breaks down myelin, and myelin in turn then turns around and triggers more mast cell release. So it can, without question, cause tissue damage. I think that whether it can be repaired is a question of an individual question based on someone else's, someone's history, sometimes, illness status, comorbidities. I do think that I know that mast cell can be managed. We do that regularly, both myself and Dr. Maitland. I don't think it can be cured because, as I've already said, we get patients very well managed. They have improvements. It allows sometimes the tissue that has been damaged to repair, some of the organs to repair, but they are very vulnerable to flares. So, again, if we nurture and we avoid exposures and we avoid known sensitivities, we could really manage it for a very long time, and patients become very functional and feel very healthy. But again, they just seem that much more sensitive to a viral illness, for example. I mean, I have a lot of long COVID patients, all of whom, that's not true, not all, but most of whom had some history, though some not diagnosed until post-COVID, of clear mast cell activation in their past, but wasn't recognized, and so was never treated along those lines. But are just very sensitive to any kind of, again, immune challenge or inflammatory assault.
Related to the damage, so is there a way to measure that loss of connective tissue objectively in any way? And can someone who's not displaying those systemic signs of EDS, hypermobility, connective tissue issues, could they have had damage done to those connective tissues and not have severe symptoms in any way?
Yes, yes, but I think that if you don't have hypermobility type EDS, I think that there's probably an improved chance that your connective tissue can heal once your mast cells are managed. Certainly, if you have mast cell activation from other reasons, and I was just giving the explanation of the mast cells within the connective tissue just for the EDS population, but obviously mast cells are everywhere. They line our guts, and so if you've had colitis or inflammatory or irritable bowel disease or a parasite even, then you have other reasons for mast cell activation. So yes, you don't have to have EDS to have mast cell activation, and if you have mast cell activation, it does release certain mediators that can damage connective tissue, and if you have otherwise healthy connective tissue, there is a greater chance for repair, certainly.
Okay. Then kind of talking about one last thing, actually, on two last things, really, sorry, on symptomatology. So can one side of the body be more symptomatic in a patient with maybe Chiari or syngomyelia? So this patient describes having one side of the body being much more numb, tingling, and burning pain being experienced with that, and headaches too, actually.
Yes, so unilateral symptoms is not uncommon. And again, if you think about the anatomical nature of some of these diagnoses, it does make sense. There is mechanical pressure that isn't balanced, it isn't symmetric. And I will say, interestingly, in neurology, there's a whole host of diseases that present unilaterally. So, this was never a surprise to me that it can present, on one side only. In fact, I have many patients that have unilateral symptoms. And long before I knew about what I know now, I think back on some of those patients and I'm like, oh, that's what was going on, So I think we're all in learning stages, but yes, for sure, it can definitely present one-sided.
A question came up: can ear popping coincide with pressure? So I know you were talking about the pressure headaches. So I guess they mean like when your ear clears, like when you went underwater or something.
Yeah, I mean, I think it could. I mean, there's a lot of reasons for ear popping, to be fair. So it's hard, it's hard to resist the tendency to want to put every symptom into this bucket, even though often it seems to be the case. But there are a lot of reasons. There are a lot of etiologies for ear popping, and so, but it definitely can, So I like to, when I have a new patient in front of me, I do like to rule out other reasons for things, right? Because we don't want to miss something. We don't want to just assume it's all related to one diagnosis. We want to rule out other things. And that's important only because it might change the treatment plan, right? If there's another reason for something and it's easily treated, I want to find it and treat it and get rid of it. So, ear popping is just one of those things. And obviously, the inner ear should be looked at and evaluated, it's obviously it is a pressure thing, but the popping has to do with the membrane and the pressure transduction across the membrane, like when you're on an airplane, right? So it has to do with that. So at the very least, like an ear exam would be important. But yes, it could be.
Okay. There was a question about syrinx. It's only about 3.5 millimeters, but is that something that could cause difficulty climbing stairs or walking? And what's the mechanism of that?
Obviously, it depends where the syrinx is.
Oh, I'm sorry. It's in the thoracic to lumbar, to T12 to L1.
Okay. And what part of, I guess, okay. So, I mean, I need to know a lot of other, yeah, a
Yeah.
lot of other questions, but I mean, it certainly could. I mean, it only just climbing, not walking,
Well, walking as well. Yes.
walking,
Difficult
just mobility in general.
mobility in general.
Okay. I mean, it could. I'd have to, obviously, these are specific patients that I'd have to obviously get a lot more information and look at the imaging and
Obviously.
to really answer that.
Okay. um, so I kind of want to get into diagnosis before we get too late. But what tests do you initially recommend when you're looking at trying to nail down autoimmune disease?
So I start with basically an immune workup and an autoimmune workup. You know, there's some basic screening labs that you can do for autoimmunity. So that's a really good place to start. And then I look at some mediators and some inflammatory biomarkers that can show that there's at least, you know, chronic inflammation happening that would result in immune activation. And so if I don't really find true evidence of autoimmunity, I look, you know, obviously I rule out innate immunity activation. So like the mast cells, for example. But you could do basic screening on the immune system, on the immune cells, as well as autoimmune labs like an ANA and an ANCA and so on.
Okay. A question about the type of imaging needed to diagnose CCI.
So we start with an MRI of the cervical spine, supine, without contrast. It's really easy to do, and we can do measurements if it's borderline or if it's not clear. You know, you could get flexion extension, which sometimes shows it more. You could get upright, which can sometimes, you know, the gravity aspect of it will make what seems like a borderline Chiari into more of a clear Chiari. But we always start with this supine cervical spine, and that's why I was talking about the three components, because, you know, I think with an MRI cervical spine, that even if it just suggests CCI and is not profoundly abnormal, you know, if there's a clinical history and a response to traction, then I don't do any further imaging at that point. Then I refer them for surgical evaluation, and if indeed that is what is indicated, then we do more of a workup with regard to other imaging. But the initial evaluation really is just a supine MRI cervical spine.
And I want to get this question because it was sent in ahead just before I miss it. Do you know whether or not cervical dystonia could be connected to Chiari, EDS, or any other comorbidity?
Yeah, I mean, I think it absolutely can be. I think I've seen a lot of, again, another diagnosis that has a lot of other etiologies, certainly. But I've seen dystonic posturing, I should say, to clarify, from certainly CCI and EDS. And some of it has been cervical dystonia for sure. It has not been the most prominent kind of dystonic posturing I've seen, but I have seen it. And it has to do with, remember I was saying that there's a positional component to some of the symptoms of CCI. So sometimes it seems that patients prefer their head in a certain disposition to their neck, and their muscles will either weaken on one side or constrict on another, because they maintain that position so often, trying to minimize their symptoms, that it ultimately becomes like a dystonic kind of presentation. So I think that so it's not necessarily sporadic, like sometimes there are some dystonic posturings we see that are just sporadic in nature, that have to do with the tension on the cord perhaps. But I think the cervical dystonia that I've seen is related again to that positional anatomical component of ways that the patients will hold themselves, trying not to be symptomatic. And that is a clear sign of CCI, by the way. When you have to put your head in a certain position on your neck, because otherwise you don't feel well, then clearly there's at least something inherent in the anatomy of the way the neck and the head sit, meet.
Mm-hmm. Absolutely. There are a ton of questions about treatment, so I want to get into those. Okay,
Okay.
so for patients whose illness seems to have been brought on by some sort of post-infectious state. So this patient specifically talks about enterovirus or cytomegaloviruses, but I think it's going to be a similar answer based on the question. So what immune-based treatments do you think are most helpful in these post-infectious kind of patients?
All right, well, first let me give the caveat that I am not an infectious disease doctor, and every time I do these talks, I get a lot of tick-borne disease kinds of questions, and I am not literate in that, although I will admit I have become much more so than I ever thought I would because of my patients. And I often defer to a lot of my colleagues who work with infectious disease, and I'm sure many on this presentation know most of them. So I am not an expert in any way on infectious disease, but I do, in neurology, and every neurologist will tell you this, there are a lot of post-infectious syndromes. The most common one, of course, being I don't know if it's the most common statistically. I haven't looked at the numbers recently, but everyone knows about Guillain-Barré because we ask about that when you get a vaccine. Have you ever had Guillain-Barré after a vaccine? So we know that there are post-infectious illnesses, and so I see everything, when a patient has a history of any kind of infection, and I agree with you, Caitlin, no matter what the bug is, I see it as basically an immune problem, because this is the infection triggered the immune system, and now the immune system is creating, inflammation where it shouldn't, or autoimmunity where it shouldn't, and so that's how I treat it. So from that perspective, I treat it with what we use for post-infectious immune syndromes, which is things like steroids, for sure, IVIG, rituximab. There's a bunch of steroid-sparing agents that I use, like methotrexate, azathioprine, mycophenolate. I mean, I can go down the list. There's a bunch of different drugs in those classes, but that's what we generally try to do to try to get that immune activation dampened a little bit so that we can reduce the inflammation and allow for regeneration. But in terms of treating the actual infection, I don't do that. And like I said, I defer to people who do.
Mm-hmm. As a follow-up to that, so in some patients that IVIG, and they also mentioned Xolair, maybe they're not working so well. Is there a next recommended step for patients where those treatments are kind of not failing, but maybe not giving the response that you're looking for?
Again, I think that's a very individual kind of question because it really sort of depends on what medications they've tried, what particular symptoms that we're targeting, what their response was. Did they even go to a therapeutic dose? I've had lots of patients referred to me that were prescribed the appropriate medication at a starting dose, but didn't get better and said it was a failure. So really it's a matter of, well, what dosing did you try and did you tolerate it? And if you didn't tolerate, what side effects did you have? And maybe there's another thing that we can use in the same class where you won't. So that, it's a long conversation and a bit of a journey and a lot of trial and error, which is very frustrating to patients. I understand it's frustrating to us doctors as well, but unfortunately there's no blueprint, and every patient is an individual and comes with their own, not only their own medical history and their own environmental history and their own medication history, but also their own genetic history. So sometimes we have certain variants that make us tolerate certain drugs and make us not tolerate other drugs, and so so again, that's sort of a hard question to really give a definitive answer. So I apologize for that, but that's the nature of human physiology. We're also different, yet we're also the same.
Yeah. So just as far as practical advice, would you maybe recommend having like a really, and I know it's a lot asking a patient who probably waited years for a correct diagnosis in the first place to keep going back to their doctor and saying, this didn't work, what do we do next? But it's just really a back and forth. And I guess it's having that patience that I can totally understand not having it anymore, but is that just the most practical way to handle something like that?
I think, yes. The general answer is yes. I mean, I do think that you should find doctors who regularly work in this space, because what happens over time, and it has taken me several years, is to really sort of know like the most promising pocket of places to start with. When I started, I would do a lot of like other things, hearing the responses and seeing the responses over years, I mean, and that's just what happens with practice in any specialty, frankly. You start to really learn, you know, where you really should start with, what you should start with first, and then go from there. And so my biggest recommendation to patients is just finding doctors, and you know, there are more and more of us every week that are really are learning so much about EDS, so much about mast cell, so much about dysautonomia, so much about CCI and connective tissue and tethered cord and ME/CFS. I mean, I'm so like impressed and excited over the future for these patients, because I mean, so many doctors are interested in learning more. And so I guess, yes, so the way it goes is a lot of trial and error for sure. And so it requires a lot of patience and a lot of trust in your doctor, certainly. But you know, if you find a doctor who's been doing it at least for a period of time, then they can certainly have a better idea of like, well, what really is the most bang for the buck kind of thing, you know, where should we really start, you know? So, but having said that, if you have a doctor who's, you know, who's new to this particular area, but is really interested, really curious, and you really trust, then that's also a person to stick with. Yeah, for sure. Because I mean, I look back and I'm grateful for the patients at the beginning of my journey in this Pentad kind of space, to be patient with me, of like learning and letting me learn from them. I mean, I learn more from patients. I learn from patients every week, you know. So I think as a doctor, I could speak for other doctors when I say that we really do appreciate when a patient trusts us, that we're trying to help them and trying to find the best answer. And if they can be patient with us, we're patient with them, and everyone's happy. And it's a patient-doctor give and take. You know, it's important. It really is.
Yeah, absolutely. No, that's a really good point too, because as long as you trust that your doctor has best intentions for you, I mean, that's who you want to talk to.
Absolutely. Absolutely.
Okay, so a question about, you brought up the synuclein neuropathy. So what treatment are you and others considering as possibilities for the POTS dysautonomia type symptoms in that regard?
So far, that doesn't change treatment or management, at least at this point. Like I said, it's been in some small studies, it's been suggested that it's just a marker of the severity of the autonomic dysfunction. But you know, the truth is the medications that we use for autonomic dysfunction are still the same. And so it doesn't really change management at the time. It's just sort of an interesting, and for me at least, exciting new piece of the puzzle that I can put into my ever expanding jigsaw puzzle on my coffee table.
So just to follow up, what medications, what treatment plan is that? I'm sorry.
Oh, well, for the autonomic symptoms, so like beta blockers and fludrocortisone and midodrine. You know, I use Mestinon for cholinergic kinds of dysfunction. Corlinor has become one of my favorites for hyperalginergic or IST. Then there's like Northera I've used, and anyway, so those same medications that, those are the ones that we will continue to use despite a positive synuclein biopsy, but it's just something else, again, to sort of put out there on our radar.
Mm-hmm. This is an interesting question. What are the latest general recommendations for the Pentad patient in terms of pain and headache management? So medicines and strategies specific for like pain syndrome.
Well, if it's headache and if there's a migrainous component, actually, we've had a lot of success with some of the CGRP antagonists, which is sort of the newer class of migraine medications. So that's been really useful. I think a little bit depends upon the etiology of the pain. So again, if it's migrainous, the CGRP antagonist class has been really helpful. If it's related to obviously intracranial hypertension, things like acetazolamide and Diamox have been helpful. Sometimes high volume taps can be really useful at reducing that kind of pain. If it's just sort of chronic daily headaches, which a lot of patients get, again, due to the CCI, but probably due to other, mast cell activation. And the interesting thing about mast cell activation is that the brain has unique histamine receptors, H3, H4. So, all those H1, H2 antagonists that everyone's using, like the Claritin and the Allegra and then all that stuff, doesn't really affect those receptors. So the histamine just, it's like the Wild West in the brain when there's mast cell activation. So, so sometimes I get really great response for headache pain from a real good mast cell, stabilization regimen. So from more of the mast cell stabilizer drugs like cromolyn, which comes in all kinds of formulations that you can play with. So I think a lot of it depends upon the etiology and type of pain, frankly. But I will say that for the most part, I mean, I think pain is one of those symptoms that we do seem to get good response to. I mean, even if you have to go down the route of, like ketamine, patients really respond well. They do. So the pain doesn't seem to be insurmountable for a lot of patients. It's usually the biggest thing for quality of life, honestly, is often the intense fatigue, the intense PEM, and I think that is usually, and the inability to do much of anything without feeling like overwhelmed from all of the the neuroinflammation that happens. So
staying with this for a little bit, there are a couple of questions about some alternative medicines, not necessarily pharmaceuticals and stuff. So I'm going to ask a bunch of them rapid fire. So what's your experience with patients and the medical marijuana? So I know that's something.
Yeah, I like medical marijuana. I like it a lot. I think it's helpful for patients. I think it's helpful for their pain for sure. That's something that a lot of my patients use. It's helpful for their sleep. It's helped their neuropathy, their neuropathic pain. So I think that when used appropriately and when you have a physician who's guiding you, I think it can be very effective for many.
Mm-hmm. And then questions about diet and nutrition basically having impact on symptoms. And actually, there was a caveat. Do you see any nutritional deficiency that might help?
I see a lot of nutritional deficiency. This is multi-layered in many ways. So a lot of patients have some metabolism disorders of some nutrients. So in fact, B12 is a common one, but then there are also others that they just have a difficult time metabolizing. But then also, a lot of mast cell patients have a lot of food restrictions. And so, some patients have a very short food repertoire of things that they can tolerate. So that in and of itself over time can cause nutrient deficiencies, certainly. In terms of, was one part of the question like diet and exercise in terms of treatment?
Yes. So just thoughts on how that works.
So, I mean, obviously most of my patients really can't engage in true exercise. But I do think that movement is life. And I think loss of movement is what creates so much despair for a lot of my patients because they lose that freedom of movement, which I think we all take for granted, frankly, that we can move. So I think movement is life in general. So I think, if a patient is able to tolerate even gentle stretching, I think that's useful. But I don't think that right now, at least, exercise doesn't seem to play an important role in treatment because patients just can't do it. And it's not appropriate to force them to do that. But I do try to, at least for my patients who feel like they are housebound, I try to at least get them to sit outside, to stand, so I do believe that some form of movement is important for the body. Even blood flow. I mean, blood flows better when there's movement. It engages muscles and it recruits certain muscles to sort of push blood around. And if you think about blood getting to the brain, it's against gravity for the most part. And so we need some form of movement, but exercise is really hard for a lot of my patients, even if it's just based on their joint pain, right? It's just hard. So good physical therapy, which is why I like guided rehab programs. These physical therapists understand an EDS body and understand a CCI body and sort of know its limitations and work with that. So, and then as for nutrition, I mean, if anybody knows me at all on any level, knows that I'm a huge advocate for nutrition and food as medicine. I mean, a lot of my social media is about like my juicing habits. And I totally recognize, listen, when I don't feel well, I don't want to eat healthy either. So I get motivation plays a role, and many of my patients are so chronically ill. I don't force anything upon them. I think I work with the basics with them. Foods can be anti-inflammatory, pro-inflammatory. It can be that simple. And so if you can choose, for the most part, anti-inflammatory foods when you have to eat, then you're ahead of the game, is how I see it. And then when patients are ready to take it the next step, I mean, I can be a preacher over it because I really do believe, again, because I know about what I know about our environment too much. Whatever we can do to combat what we're breathing in and what we're drinking and what we're touching, I think we should do, and that comes from real good nutrition, which really can support our immune system. So I'm a huge fan of food as medicine, but also know its place and know its limitations. So I do believe it can play a role. Yes, that was a long-winded answer to your question, but
No.
it is something that I'm very interested in.
Do you have any comments about some like supplements? Are there supplements that you think might be helpful at all, and what those might be? I mean, I know it's kind of harder.
Yeah, I think, I think supplements have a role. I think supplements have a place. I think that for what we were talking about tonight, at least for this conversation with this Pentad patient, I would say that supplements are not powerful enough to really have much of a great effect. There are a couple of exceptions to what I just said. I think quercetin is a very great mast cell stabilizer and antihistamine. I think PEA, palmitoyl-ethanolamide, is a powerful lipid autocoid that can really help. We lose, when we have chronic inflammation, we lose that endogenous stopgap that we're all sort of born with, because again, it's such a perpetual inflammatory assault. PEA actually helps to implement that stopgap and sort of reduce the inflammation and really helps our body fight it. Obviously, I think vitamin D and vitamin C are important for our immune system in general, but I think beyond that, I see patients come in on 30 different supplements and they're still just as sick as they were when they started it, and it's not that supplements are bad and it's not that they don't have a place, but when we're so chronically ill and so chronically inflamed, they're just not powerful enough. And and a lot of them are water soluble and you end up peeing it out. A lot of them have to be metabolized by your own gut, and sometimes that's inefficient and you pee it out or you poop it out. So I think that, again, I think when I get patients to a healthier state, when things are better and they have better quality of life and their organ systems are working a little bit more in a functional manner, I do recommend certain supplements. I think certainly for headaches, there's been research, neurologists regularly recommend things like magnesium and riboflavin, and I'm a big fan of boswellia for headaches. It really reduces neuroinflammation and cerebral edema. I think, there are places for that, but when we're in such a chronic state, I worry that it could potentially be a waste of money, at the very least. And then, we don't really understand all the interactions with the different supplements and their excipients and the role that they're even playing in mast cell activation. And it might not be like they get full body hives. We might not notice the effect that they're having of the excipients, but they're not feeling, so I guess there's a lot of questions that I prefer to have answered before I recommend a whole host of supplements to a patient. But like I said, there are exceptions to that. I think there's a handful of them that I think do have a role in patient care. And my patients, I tell them what they are, so my patients know.
Yeah, absolutely. And I could get on a soapbox about how there's less in there than you think you're paying for. So, but I won't.
That is for sure. That is for sure.
But so, are there any other specific lifestyle changes or even alternative health practices? I know a lot of people talk about acupuncture and yoga, and I know, again, like you were talking about before, there's a limit to movement even as well. But what do you generally recommend for these patients?
Well, a little known fact about me, I'm actually a certified medical acupuncturist. So I love acupuncture and I do it in my clinic here in Seattle. In fact, I'm going to be taking some needles with me to my next trip to New York so I can offer it for patients. I think that there are some real powerful spots for acupuncture that have been very, very effective. So I'm a big fan of acupuncture. So yes, so I like acupuncture. And you mentioned one other thing. Oh, yoga. I mean, again, the yoga along with the exercise that I've already answered. But if you can get yourself to a gentle yoga session, and that's something that you can do, I think it's great. Actually, I think it's important. Again, movement is life. Yoga really sort of does put you in positions that some patients can hold, and it does recruit certain muscles that are important. It also helps blood flow. And so it can definitely help minimize some symptoms, at least for the time being. And, yoga has other kinds of benefits, frankly, for the central nervous system. In fact, yoga and meditation have been proven to improve depression, to improve sadness, to improve anxiety. In fact, there were several studies done several years ago that were published in some of the neurology journals that showed that regular meditators actually had greater volume of their temporal lobes, of their hippocampi, and even some had atrophy, or at least smaller volume. Well, I shouldn't call it atrophy, but smaller volume prior to starting their meditative practice. And then 6 weeks after doing regular meditation, they had greater volume to those regions. And those regions are responsible for memory, for some cognition. So this is proven, right? So meditation, you don't have to go anywhere for. You can do in your own home. And I often help guide patients through a meditative practice, even for 5 minutes, if they can. But yoga has a similar kind of meditative benefit as well. So I like yoga for that reasons. And again, it depends upon the patients. I mean, some of my patients have no problem going to a yoga class, but some do have difficulty. So it really depends upon what a patient can accomplish.
Mm-hmm. There's just 2 more questions kind of about alternative methods. So as far as physical therapy, this isn't really alternative, but one patient had written in asking about if it was odd that their symptoms kind of regressed. So can physical therapy do harm? I guess, can you overdo it in physical therapy, and how do you know?
Yeah, a resounding yes, you can. Yeah. A couple of things. So you need an EDS literate physical therapist, and I love physical therapists. I did, like I said, I did some neuromuscular, and so I worked with a lot of physical therapists over my career, and I think that they're all awesome. But I know for the EDS patient population, you need someone who at least is familiar with EDS, and you also need someone who's going to listen when you say this is too much. I think some physical therapists just want to do good. They want to help get you better. But I think that and some patients I think maybe are a little bit too timid to sort of speak out against their therapist, and speak to their therapist and say, that's too much for me. But they should. And all the physical therapists that I know that work with my EDS population are phenomenal, and they totally get when it's too much, and they will back off. And so I do think that that's important. And again, it goes right back to the interaction between the patient and the therapist, right? I mean, everyone's got to be receptive to each other. We're all humans in the end, right? And we're all trying to do something good. And so it's the communication aspect is so important to me. It's so important. So it's similar with the therapist as it is with the doctor, with what I said earlier.
Okay, so we still have a lot of questions, so I'm going to try to get through them as fast as possible.
It must be late for a lot of people, isn't it? It must be go to sleep.
As long as you're okay to stay on, I know people have stayed. Okay.
My husband's not even home yet, so.
Okay. So back into treatment. I know there are limited resources, and a lot of the times you and other clinicians have to make kind of difficult choices about how to prioritize what to treat first. So especially, this patient says very intelligently, these conditions can have similar symptoms, and they can often exacerbate each other. If you fix one, you kind of mess something else up. So if you're dealing with something like temperature dysregulation, do you treat dysautonomia or small fiber neuropathy first? And then what about vascular symptoms that might be playing into that? Temperature dysregulation, I think, and specifically.
Specifically? Well, temperature dysregulation is an autonomic component. It rarely presents in isolation. So, you rarely are just treating temperature dysregulation. Usually there are other autonomic symptoms that you focus in on. I mean, most of the medications that we use for dysautonomia have to do with blood pressure and heart rate for the most part. So yes, you could try to treat small fiber neuropathy, but how does this small fiber neuropathy present? So it could present as pure neuropathic pain, certainly. And so you can try to treat that, and then that might improve the temperature dysregulation because it is related to the small fiber neuropathy, as the small fiber neuropathy relates to the autonomic system. So you could just treat the neuropathy basically. And again, pharmacologics are usually, the neuropathic pain meds, which is where you start. And sometimes you do get, in fact, gabapentin has helped, a lot of patients tolerate different, or I should say abrupt changes of temperature, which is really where the problem lies. So like, they go from an air conditioned house into the 110-degree desert in Arizona, and they, have a fainting spell, right? So it's the abrupt change of temperature that seems to be more problematic than an insidious change of temperature. So, I think that, so there's an overlap basically. So, if you treat the small fiber neuropathy or you treat the autonomic dysfunction, you can generally get an improvement in other symptoms. In terms of I think the concern is that if you treat one, will it exacerbate another? And that is sometimes the case. And sometimes we have to do a little investigation as to why, because it's usually about something that we have not yet acknowledged or identified or treated. So there's usually a reason behind it.
Okay.
And those kinds of things, by the way, that I think there's a big spider on my wall. Oh no. Seattle. Where's my husband? Come home. I forgot what I was saying now. My spider lost my train of thought. Oh, it's those kinds of things that it's that kind of history that is important to your doctor, because it's that kind of piece of history. Like if I regularly use this to treat that, and you say that it did treat that, but then this got worse, and that's something new, then that's a piece of history that's very specific to you as a patient, that is important to your doctor, because it makes us think a little bit more about what more is underlying your presentation that we have not yet identified. And so we can perhaps find a better treatment plan. So it's those kinds of and that's where the complexity comes in, right? So everyone is individual. And so it's those kinds of things that's important to communicate with your doctor.
Yeah, absolutely. There was a question about adrenal insufficiency and how that factors into these things. So this patient says, I know a lot of people with Pentad symptoms who end up diagnosed with adrenal insufficiency. So what's that mechanism? And is that something that needs to be treated first, or is there a priority there too?
So that goes back to the neuroendocrine axis that I was referring to, that is often offline. And so I usually test the full axis, which is not always done initially, but over time, if nothing is improving, it's important to sort of assess that the function is there. And so, and then, so cortisol, though, is usually tested immediately, so you can sort of see if the adrenal glands are up online or not. But sometimes it's more upstream is the problem. So I do the whole, neuroendocrine axis, but it needs to be addressed, certainly, because if you have adrenal insufficiency, and if it's real, I mean, I think chronic fatigue over time burdens the adrenal glands. And so sometimes it's, the answer is not just, well, supporting the adrenal glands, because then you sort of get into this, this cycle of giving the adrenal glands its own hormones, and then it doesn't endogenously want to make it anymore. So sometimes you have to try to treat what, other kinds of symptomology. But if it truly is your adrenal glands are kaput and just can't find their way back, then you really do need to support them, because that is an important component of recovery and healing, of course, especially, by the way, if surgery is indicated. So these are the kinds of things that we do preoperatively to make sure that everything is, set up for optimal recovery after the surgery, and optimal healing. So yes, I wouldn't call it necessarily an emergent. I mean, it could be an emergency, obviously, especially if you're postoperative and your adrenal glands aren't working. But it's something that's usually regularly looked at and supported when needed.
Mm-hmm. There's a question about, this is kind of different, but what other reasons would a patient end up with myoclonus seizure if they've already undergone surgery for CCI and tethered cord? Is that something?
So myoclonus is, it could certainly be centrally mediated. It could be, there's spinal cord myoclonus. I mean, it sort of depends what people are calling myoclonus. I mean, so there's a lot of different kinds of abnormal movements that often people will label as myoclonic movements. They're not always myoclonic. And so you could definitely have, even if you've had the fusion and the SFT, and there are other reasons to have abnormal movements in general, but also if you think about compression of vasculature, and so poor blood flow, poor blood supply, hypoxia, these are reasons. Even if you think about they're not necessarily seizures in an electrical sense, but you could have post-hypoxic abnormal movements. I mean, kids get them all the time with their breath holding spells. And I often give these as an examples to not only patients, but to some doctors that I work with, I did pediatric and adult neurology, so I often harken back to like what I remember seeing in kids, like, they hold their breath during a temper tantrum, or they hit their head and they hold their breath, and then they get hypoxic and they convulse. And immediately neurology is called because they think the child has a seizure disorder, but it's a post-hypoxic convulsion. And so I've seen, in a small percentage of patients, I wouldn't say this is commonplace, but I've seen in a small percentage of patients where because of compression or stenosis, there is hypoxic kinds of positions that can result in what seems like a post-hypoxic kind of convulsion that can sometimes look myoclonus for sure. So that's one, just one thought I had about those kinds of things. But again, there is spinal myoclonus as well. And so when we think about tension on the cord or damage to the cord, those are kinds of things that we can see. And then there are all other kinds of systemic reasons why there could be myoclonus. I mean, there are lots of benign myoclonic disorders. I mean, so, that's also something to recognize. It's, not always like a scary, epilepsy kind of presentation. In fact, it usually is not. In fact, very often, if not always, the EEGs are normal. And again, it's because it's not an electrical cortical problem, which is what the EEGs pick up on, right? They're surface electrodes, and so I think that it's multifactorial, frankly. So I hope that answers the question.
I think so. There's a couple of questions about fusion specifically, but I'm going to start with this one. So have you seen circadian rhythm disorders with CCI? I think you talked about that a little bit, particularly non-24. And have you seen resolution after fusion of this type of thing?
Yeah, so yes, I have. And yes, I have. I actually, in fact, the circadian rhythm disorder very commonly improves after fusion, interestingly. I always say that patients with prolonged CCI, where it's in the realm of ME/CFS, frankly, their bodies are always particularly sensitive to things. And so they have great response after fusion. They're walking again, they're sleeping again, they're cognitively intact again. They feel like they can do mild exercise again. But they're very sensitive. It harkens back to the cell danger response that I often talk about, but Dr. Navio first described it. The cells go into when the cells perceive danger, it's like high alert, and they go into basically a cell danger response, which are separate phases. And in normal times, there's a danger, they perceive a danger, they go into the cell danger response, which protects the cell and thereby protects the organ, and it comes out of those phases, and then it comes back to baseline. But during the cell danger response, it doesn't speak to its neighboring cells. And so what happens when that communication is cut off, every organ requires a critical biomass to function appropriately. And so when the cells are no longer talking to one another, there's a functional loss of biomass, right? Because the cells are just sort of hanging out by themselves now. They're not talking to anyone because they're in a cell danger response. So I often think that, an ME/CFS patient, even though they have great improvements after fusion, they're not completely out of the cell danger response. They're sort of, at the end maybe, but they haven't yet completed all the phases. And so the cells are still that much more vulnerable. I refer to it as being hypervigilant still. And I think for a long time thereafter, frankly. And so I think, and that relates to the question with regards to circadian rhythm disorder. They definitely improve, and I know that for a fact. I see it all the time. They sleep better, but little things can throw them offline again, where they're not sleeping again, and then of course it becomes a cycle. And we all know how we don't feel well when we don't sleep even one night. And so it's important that we address it quickly, and we try to find our way back, and then they have a better better chance. And they tend to, and it doesn't evolve back into where they were. I will say that. We do find a way back, because after the fusion and after the tethered cord release, they are more anatomically prepared to receive, interventions that sort of help more metabolically and more systemically. So,
yeah. About the fusion, there are two other questions about it. So first of all, are there any data on like the long-term outcomes from fusion? So this patient's basically asking, how are we going to be sure that the hardware is going to stay in place with that hypermobile EDS, the poor wound healing, mast cells being activated? do good outcomes last a long time? Do you notice, or what do you think?
I think it's too soon for us to say for sure because we haven't been doing this long enough. So we don't have like 30-year data. We are collecting data literally as we speak. That's what our research, is focused on as well. Obviously, there's a risk for every surgery, and there's a risk for any surgery that includes hardware. And I don't think that this risk is any greater than other surgeries that require hardware. Hardware can fail. It's a well-known risk and it's a well-known complication. I don't think that and again, I don't know statistically, so, and that's probably a question for the neurosurgeons. And I could certainly find that out, I can ask, but I don't think that there's a greater incidence of hardware failure in the EDS population. I will say that we do identify bone health. So what we regularly do preoperatively is we try to assess bone health. I mean, osteopenia, if not osteoporosis actually, is very common even despite the young age of these patients. So there's some bone metabolism issue that we haven't yet completely elucidated, but we do assess bone health going into the surgery because obviously the bone has to hold on to the hardware. And then when, at least, because I speak with Dr. Bolognesi after most of the surgeries, he describes the bone that he had seen and the bone that his hands were on. And sometimes he says it was very porous. And so we put patients very regularly on, basically osteoporosis drugs, frankly. But preoperatively, I put them on a bone health program, which is a couple of, supplements, and we talk about, weight bearing and nutrition for bone health. So I guess my point is that, we try to optimize it as best as we can so that the hardware doesn't fail. And then we do guide with certain exercises and when you can do certain things during recovery. Again, all in the effort to try to maintain the hardware, allow your bone to overgrow the graft that's placed. And if we do that, then you have great chance of maintaining that hardware stability for a long time. And again, we just don't have the data for years out, but for now, that's what we do.
So data on how surgeries do for a long term is more of a surgeon's thing, but this is going to be kicked back to you, really. So what does a patient do if CCI surgery or a tethered cord release aren't really giving significant improvement? So I assume they're going to come back to your office and say, help. What do you do after, quote unquote, a surgery fails or isn't really necessarily fixing what we thought it would? What's the next step?
So again, which is why there's a lot of workup that goes in before we decide surgery is the answer. So, there's a really good chance you'll have some benefit from surgery because of all the work we put into it, in the front loading of it, right? So we don't just forward you to surgery and just sort of see what happens. We really do a full evaluation and we come to a fairly confident conclusion that surgery is really the next best step for you. So in that regard, I think that there's a level of confidence that if we've recommended surgery, we really do think that there could be a benefit. And obviously there's no guarantee. So if we either don't get any benefit or we get less benefit than we expected, then yes, it comes back to me. And then we try to find reasons why. So what else could be causing the symptoms? And again, we've already confirmed that there's CCI. So it's not as if we're doing cervical fusions on a patient that does not have CCI. We've confirmed that diagnosis, and again, that's why those three components are so important in order to confirm that diagnosis. But what we learned if you did not get a response from surgery is that CCI wasn't necessarily the cause of your symptoms. It did exist and we fixed it, so it shouldn't ever really be the cause of your symptoms, but there's something else going on. And so then we do, more workup and more evaluation, which I try to do, to be honest with you, before surgery. Even if CCI is thought to be the reason for the symptoms, we do try to find if there's other reasons that we can address as well. So that's what we would do if you don't get a benefit from surgery. We would look elsewhere.
Mm-hmm. So I don't want to keep you too late, but I'm going to ask you just one more. First of all, would you be willing to do this again? Because there are so many other questions that I just don't think we're going to get to. Okay, yep. Great. Secondly, I usually try to end with, I know you sort of mentioned this earlier, but are you still accepting new patients? How do patients get in touch with you? Can you do telemedicine? How do people learn your insurance that you take? Like, basically, how can people get in touch with you if they think that they might need to see you specifically?
So you can see me at Mount Sinai. So as I said, so I'm only there. I'm only physically there. Right now, I'm going to be there in 2 weeks, but I know I'm already booked. I'm going to be there again in March is the next time that I'm scheduled to go. But I do, like I said, a lot of telemedicine, so you can schedule appointments with me. I believe I'm even booked there until March. I still am maintaining a small private practice in Seattle while I'm still living here. Obviously, I won't anymore when I'm permanently in New York, which probably, to be honest with you, won't be until fall of next year. So for now, I still have a small private practice in Seattle, of which I'm not currently taking new patients, but in the new year I plan to. So not right now, but in January, my assistant Natalie will take some new patients. So those are the ways that you can see me. But I mean, there's a lot of people like me. So you're just hearing me talk because I like to talk. And but there really are a lot of doctors across the country. So obviously if you're in Seattle, that's nice. If you want to come see me in New York, that's nice. But there's a lot of patients across the country, a lot of doctors across the country that can really help as well. But if you want to see me, then you can call Mount Sinai, and I can give you the number, which I know that. So I know that probably some people who are listening, if anyone is still listening actually at this point, but I know that they've called and have had problems with this number, but it really is the number, and we've just gotten loaded with calls. And so we've actually just hired 2 new people. One is starting next week, and I think the second is starting the week after. And I think they're going to be great, and we'll catch up on all of the calls. So the number for the office is 516-374-8566. Having said that, I also should say that if CCI is your big concern, then we have a particular workflow that we're using. So if this is more of like, a Pentad kind of diagnosis that you want to see me about, then that's the number to call. But if it's CCI is at least I realize that CCI doesn't come in isolation because usually there's the Pentad as well. But if you have a question about CCI, our workflow is that you start with our screening coordinator, Jeff Wood. And if you go to our website, it actually has the contact information for him, and his email. I believe it's jeffrey.wood@snch.org, but our website is chiariEDScenter.com. So I think you all know how to spell Chiari, EDS Center, all one word, .com. And yes, that's it, exactly. And so it actually describes sort of the workflow for new patients. And it starts with Jeff Wood, who's been awesome. And he sort of gathers all of your information and all of your records and all of your imaging, and gets everything in order, and then reviews it and sends it on to me. If you've already had a diagnosis of CCI, then he sends it to Dr. Bolognese. So we have that pipeline down fairly well, thanks to Jeff, frankly. Actually, he's been a godsend in helping us with manage and triaging patients. So that I would recommend just looking at the website and sort of seeing how that works.
Perfect. And then about the slides, you said that we would be able to share them. I don't want to share them unless you for sure that you said.
Yeah, okay. So there's a bunch of this is a part of a very long presentation that I gave for an organization. So some of them are hidden. So I'm gonna just remove the hidden ones, and I'll send it back to you again, and then you can share those as well.
Awesome. All right. And then there was one more question. I'm gonna put it in the chat. There you go. That's to access Dr. Ruhoy at Mount Sinai. Thank you so much for doing
welcome. No, thank you.
To come back. There's been so much that we had to get to. But no, this was great. Thank you so much for doing
You're welcome. Have a good night, and have a good night, everyone who's listening. Okay. Bye-bye.
Thank you.